how those flows are controlled and what factors might influence them, and how inappropriate control of those circumstances might lead to the generation or continuation of symptoms. And of course, the symptoms that we're interested in are those which I'll describe later, but unfortunately those those are the symptoms which affect individuals with chronic fatigue syndrome and some other similar entities such as orthostatic intolerance. Before I go into large detail about what we do, I want the audience to appreciate the fact that our research is not designed to answer the question per se of what's wrong with me, how can my symptoms be alleviated or cured. I recently, in a conversation with an individual with chronic fatigue, described what we do as fabricating an individual piece of a jigsaw puzzle. We know what the whole picture should look like, but we only have the ability and the facilities to work on characterizing or formulating one piece of that puzzle. And the work that we do, the work that our colleagues do, the work that other investigators do, hopefully at some point in the future will ultimately be integrated into a total picture which gives us more understanding of the pathophysiology, or that which goes wrong in people who exhibit symptoms of chronic fatigue, orthostatic intolerance, or as Kim mentioned, POTS, postural tachycardia syndrome. The talk that I'm going to give today is eclectic in that it's fraught with scientific terms, technical descriptions, and I recognize that the audience that's listening today is a very sophisticated, very well-educated and informed group of folks. Nonetheless, I'll, despite the fact that I'm a New Yorker, I will try and speak slowly, and I will elaborate on as much as I can. And certainly if there are any issues, concerns, or questions, you can convey them to Kim, and when appropriate, she will forward them to me. That being said, I'm going to get started and show you this first slide, which describes the hypotheses that were proposed to the CFIDS Association when I applied for the grant, and essentially what it speaks to is the fact that when individuals stand up or change their physical position from, let's say, lying down to standing or from sitting to standing, there is an inappropriate transposition of blood from the upper chest area where the heart pumps from, and the blood moves to reservoirs below the heart, and decreased systemic return is impaired, and that impairment is what may lead to symptoms associated with chronic fatigue and orthostatic intolerance. We don't have to go into all of these individually. Suffice it to say that there are many study objectives that were proposed in order to answer the questions that we want to ask. The first objective clearly is to design a system whereby we secure and solicit the participation of both control subjects against whom the results from chronic fatigue symptom subjects will be compared. It sounds easy, but it takes the coordinated effort of many of our staff members, all of whom are healthcare professionals, to accomplish this, and we solicit invitations for participation here at the Medical College through web-based advertising, much of which is supported by the CFIDS Association. Once we have potential candidates, we then have to screen them to see whether or not they are considered to be healthy, thus would serve as control subjects and whether or not they satisfy the criteria for chronic fatigue syndrome. This gives us the basis for comparing these two groups. I might also want to mention that all of the studies that we do, since they involve humans, since they involve sensitive healthcare information, all of the studies that we do, of course, are approved as being appropriate to conduct by the New York Medical College Committee for the Protection of Human Subjects, the so-called IRB, the Institutional Review Board for the Protection of Human Subjects, and every one of the subjects, including the control subjects, are required to sign an informed consent so they know just what we're doing and what their expectations are. Once we've gone through the formalities of recruiting and enrolling subjects, then we do many, many measurements, each of which I'll go into somewhat more detail about. But what we're basically looking for is are the differences between control and chronic fatigue subjects in terms of how their blood flow from the heart changes when stressed, and I'll talk about what type of stress we induce in just a few minutes. We're also very interested in looking at aspects of cerebral blood flow, because one of the common symptoms for both chronic fatigue and POTS and orthostatically challenged individuals is something that we commonly hear as these subjects experiencing brain fog or mental clouding, and we've just published a few papers showing the relationship in certain individuals with orthostatic challenge and cerebral blood flow. And we just recently obtained a device that's called a NIRS, which stands for Near Infrared Spectroscopy, which will allow us to compare changes in brain blood flow measured by ultrasound with the level of oxygenation of certain parts of the brain in an attempt to see if we can correlate what changes in blood flow might result in utilization of oxygen. We also, because the skin can be, under certain temperature conditions, the major repository of blood in the body, and thus serves as a large reservoir. We will be examining, we have been examining and will continue to examine some of the biochemical factors in the blood and in the skin circulation that may control the pooling or lack of pooling of blood under certain conditions. So those are many of the study objectives, and we, as many of you are aware, we don't exist in a vacuum in terms
Marvin?
of the... Yes?
Can I interrupt for a second and just put out
Certainly.
a poll to see how the sound is for people? So if all of you will take a second and let us know about the sound that you're hearing through your computer, that will give us a sense of whether we need to speak more loudly or maybe whether you need to check the volume on your speakers. And okay, it looks like with 80% voting, all of us, both of us are being heard, and looks good. So
Okay.
I'm going to do one other while I've got you stopped there. No, go ahead. I'm sorry. We'll save that.
All right, so shall I continue?
Yes, please.
Okay. What I was saying before was that our research, as most research in the endeavor of human disease, is seldom done in a vacuum. And in fact, one of the benefits of our association with the CFIDS Association is that they are very masterful at coordinating our efforts with those of others, and as this flow diagram shows, we actually work with several other local investigators, each of whom is very experienced and well published in the area of chronic fatigue. Many of you may know the name Benjamin Nadelson, and Dr. Nadelson is one of our consultants who assists in our evaluation of subjects to assure ourselves that the subjects that we are enrolling in fact have chronic fatigue syndrome and not other mitigating factors which may appear to be chronic fatigue, but in fact these patients may not have chronic fatigue syndrome. In addition to my working with Dr. Stewart, Julian Stewart, we also are in close collaboration with Dr. Dikoma Shungu, who is at Cornell University Medical College, and his colleague Sanjay Matthew, who is at Columbia University. They are doing some very, very interesting brain scan studies using sophisticated MRI equipment to look at local brain metabolism and to see whether or not folks with chronic fatigue syndrome utilize nutrients in their brain differently than non-chronic fatigue syndrome individuals. We all work, that is, that if Dr. Shungu gets subjects directly from outside references or through Dr. Nadelson, they eventually wind up in our laboratory. Conversely, we refer patients to Dr. Shungu, and we've had a lot of success in sharing of patients, and hopefully the coordination of our studies along with those of Dr. Shungu once again will add another piece to that jigsaw puzzle. One of the things that we do, and I'll talk more about it, is we do tilt table testing, which allows us to impose an orthostatic challenge to see what the cardiovascular response is to that challenge. And I'll go on to talk a bit more about it, but what we basically do is we segregate our study population into those that have chronic fatigue syndrome with POTS, or NMH, neurally mediated hypotension, versus those patients with chronic fatigue without the orthostatic challenge. This is what appeared in my grant proposal, which is what we're working to achieve. We haven't quite achieved full enrollment, but we're basically looking to recruit subjects 15 to 29 years of age. Actually, we've recently increased this. It's actually 15 to 39 years of age. We expect to enroll 15 controls, 15 subjects with chronic fatigue syndrome alone, and another 15 with chronic fatigue syndrome and POTS. I spoke before about the methods that we employ, and there are lots of them. Essentially, study subjects, be they control or chronic fatigue subjects, come into our laboratory, and they spend the better part of a day because we hook them up, so to speak, and we put all sorts of gadgets and gizmos on them that allow us to continuously monitor and record their heart rate, their blood pressure, their respiratory volume, their rate of respiration, and very importantly, their end tidal carbon dioxide. Now, as all of you know, we breathe in oxygen, and the waste product of our metabolism is carbon dioxide. And I'll speak a bit more about carbon dioxide later, but carbon dioxide is a very important regulator of many body functions, including brain blood flow. In addition, we have a rather sophisticated method of changing the distribution of fluids within the body, predicated upon the fact that our blood contains ions, and we can actually, through something that's referred to as impedance measurements, look at the change in resistance across different body segments, thus allowing us to make estimations of changes in the distribution of body fluids. In addition, as I mentioned earlier, because the skin is a major repository of fluids, we use skin, we make continuous measurements of skin blood flow by laser Doppler flow measurements, which, as I'll show you later, are non-invasive. They involve placing small laser lights on the surface of the skin, sort of like the similar to the oximeter, that little finger gizmo that people have put on if they're unlucky enough to have to go to the hospital, where it measures degree of blood oxygenation. This is similar. There's a small laser that sits on the surface of the skin. It shines a laser light through the skin. The laser light bounces off of blood flows that are blood cells rather that are flowing by, and the reflected light is measured and gives us a good index of the amount of blood that's flowing in a small area of skin. Much the same way that we can challenge the heart by putting folks on a tilt table and tilting them, we also like to challenge the skin, and we can do so in one of two simple ways, either by heating the skin that the laser is looking at, or providing local drugs to the skin area that the laser is again looking at. And I'll clarify that by showing you some slides a little bit later. Insofar as the blood, the brain blood flow measurements that I mentioned earlier, we use transcranial Doppler measurements, which, as I'm sure everybody knows, is a non-invasive way of measuring brain blood flow in selected areas of the brain, and I'll show you a diagram of just what we look at. And from those measurements, we can do calculations to look at various factors, among them are flow dynamics and coherence, and the issue of coherence, that is the relationship between brain blood flow and, for instance, blood pressure is very, very interesting, and we've shown some alterations in certain subpopulations between control or normal individuals and people who are orthostatically challenged, and I'll speak a bit more about that in detail later. In addition, it's been recently published and has been our experience, and I'll show some slides to substantiate that in our population, that many individuals who are either orthostatically challenged or have symptoms of chronic fatigue, in fact, have been shown to have decreased blood volume. We previously measured blood volume in research subjects using an experimental method with a substance called indocyanine green. We no longer use that because there's been the advent recently of a radioactively tagged determination of blood volume, which is very sensitive. It actually involves minimal, very, very low levels of radiation, and gives us a very good indication of blood volume. So those are some of the measurements that we employ. And what we do is we use the diagnostic criteria for chronic fatigue along the lines of those described by Fukuda in 1994. And any of you out there with chronic fatigue recognize some of these. This certainly is not a listing of all of the criteria, but among the more frequently reported is impairment of memory or concentration, the so-called brain fogging, mental clouding or impairment, muscle pain or focal joint pain, headaches, none or unrefreshing sleep, post-exertional malaise lasting for more than 24 hours, and paramount in all of these is fatigue. Now, in our patients, recently, 80 to 90% of the subjects that were initially referred to us for chronic fatigue syndrome turn out to have POTS or postural tachycardia syndrome as well. The next two slides are, I find rather interesting because they are a depiction of most of the symptoms that folks with chronic fatigue syndrome report. And I'm going to flip back and forth for a second, and the reason why will become obvious. And these are symptoms of orthostatic intolerance. Note that folks with orthostatic intolerance have lightheadedness, headache, fatigue, neurocognitive disorder, etc. And the previous slide, which is symptoms of chronic fatigue, mirror virtually all of the symptoms of the orthostatic intolerance patients except for the fatigue, which is somewhat lower down on the list, but certainly reported in orthostatic intolerance patients. There's therefore a great deal of homology between these two patient groups, which is why we study them both. Now, for those who are not as familiar with the criteria for POTS, or postural tachycardia syndrome, it's defined in adults as day-to-day symptoms of orthostatic intolerance and an increase in heart rate of greater than 30 beats per minute, or a heart rate of 120 beats per minute within 10 minutes of upright tilt. Interestingly, this was first codified and described by Schoendorf and Low in 1995, which is the same time frame as the formalization, so to speak, of symptoms for chronic fatigue syndrome by Fukuda in 1994. So that's just an ironic similarity. Our patient cohorts that we've seen over the years can be described generally with these criteria. There's a preponderance of female to males. Many of the symptoms, as in chronic fatigue syndrome, are described after an intervening infection or some inflammatory process. The majority are Caucasian. It occurs between menarche and menopause, and it can affect athletes as well. What I referred to earlier in terms of control of fluid and fluid dynamics is graphically shown here with a depiction of the human versus, for instance, a quadruped, our friend the dog. Quadrupeds do not, at least as best we know, experience symptoms of orthostatic intolerance because 70% of the blood volume is at or above the heart, making the major fluids for pumping by the heart readily available. However, in contrast to quadrupeds, humans, when standing, wind up having 70% of blood volume below the level of the heart. Therefore, in order to maintain perfusion, particularly of the blood vessels that feed the brain, the heart needs a constant and steady and uninterrupted and uncompromised return of blood to the heart. And if the mechanisms for returning the blood to the heart are altered or impaired, as we believe they are in certain of these conditions, then the heart simply doesn't have enough blood to pump, and people experience symptoms. One of the ways that we can reproduce some of these symptoms is by strapping people onto what's known as a tilt table. I'm sure that there are several individuals, many perhaps, who are listening today who have either seen, have considered using, being tested by, or who have actually been on a tilt table. This actually happens to be our tilt table. This is a tilt table that you can see over here is part of NASA, which is why it looks infinitely more sophisticated and certainly much more expensive than what we have, because it's been paid for by our tax dollars. Nonetheless, what we do is we ask the patient or subject to lie flat for about 20 or 30 minutes, during which time the blood equilibrates and just distributes laterally. We can use this gentleman here. It just distributes laterally to the chest and the legs and the arm and the head. And then within a matter of seconds, the table is tilted upright to about 70 degrees. Different laboratories use different angles, but the objective is twofold. Number one, to tilt the subject to near vertical, and number two, to maintain with straps or restraining devices the subject to remain motionless, because one of the mechanisms that we as humans have evolved to facilitate moving blood back to the heart is something that's known as leg muscle pumping. So when we do the tilt, we ask the subjects to remain motionless, and we therefore impose a great orthostatic challenge. Now here is the response in terms of heart rate and continuously measured blood pressure to an orthostatic challenge. Now you can see this individual who has POTS. Let me get this. The individual here that has POTS was diagnosed as having POTS. Right over here, this vertical line is the imposition, is when we tilt the table up. So this area to the left of this line represents the subject lying flat on their back, supine, and you can see their heart rate is average is about 60 beats per minute, and their average, this is their average blood pressure, and you can see their blood pressure is averaging about 70, 80 millimeters of mercury. Once millimeters of mercury pressure, once the table is tilted, you can see that there is a steady increase in their heart rate, which remains elevated until this point where we put the table back to supine, and you can see that their heart rate comes back to its resting value. Now, interestingly enough, this individual did not faint. A faint would be demonstrated by a rapid decrease in blood pressure. Now, I talked earlier about the importance of respiration. This is a comparison of control subjects to subjects with POTS during the imposition of a tilt. And the beginning of the tilt is the first line, the end of the tilt is the second line. Let's look at the control subject first, which shows that their resting heart rate is somewhat elevated in controls, and then once the tilt starts, their heart rate goes up, and that facilitates the return of blood to the heart. And then when the table goes down, their heart rate drops to the pre-tilt level. You can see that this panel here shows the relative respiration volume, that is how much air is being exchanged through the process of breathing, and you can see that there's a bit of change but not a lot of change in the rate and depth of respiration, and you can see that there isn't much change in the carbon dioxide. This is a measure of end tidal carbon dioxide, the carbon dioxide that's blown off or that you breathe out at the end of each expiration. Compare this, however, to subjects who have POTS, and as shown in the previous slide, once the tilt is imposed, you get a steady increase in heart rate, but look at what happens here to their respiration. Individuals who are orthostatically challenged, as in patients with chronic fatigue, once challenged, demonstrate a large increase in both the rate and depth of their respiration. And what winds up happening, since these individuals are experiencing an increase in both the rate and depth of their respiration, their end tidal CO2 drops precipitously. This is a key controller, the carbon dioxide, of many things in the body, including brain blood flow, and we'll talk about that later. So you can see here quite clearly and dramatically that there are large measurable differences in control versus POTS, or what we found as well in patients with chronic fatigue as well. Now, I mentioned earlier that we can, by virtue of the fact that blood contains ions such as sodium and potassium, which carry an electrical charge, we can, by measuring the resistance across certain parts of the body, estimate the change in the distribution of fluids within the body and in response to an orthostatic challenge. Here's a depiction, although somewhat distorted, of an individual, and what we measure is the volume and change in distribution of volume within the thorax or chest versus that which is in the splanchnic or the gut versus the upper leg and the lower leg. And these little dots here actually represent the way in which we do it. We put a little electrocardiogram stickers on these at these various locations. These are attached to wires which can measure the change in resistance in response to a challenge. This slide is from an older publication which shows the change in the percent blood volume when subjects are tilted. And here we can compare the control, the open boxes, to subjects with POTS. And as I said, this compares quite comparably to what we see in many subjects with chronic fatigue syndrome. This is somewhat of a simplification because our laboratory has used these sorts of measurements to subcategorize various populations of people, individuals with orthostatic challenge, who are rather orthostatically challenged. But this is a very interesting slide to show a generalized difference again between control and POTS, and this shows the relative change once a tilt is imposed. Now, what we find, and again, we're looking at the thorax, the splanchnic or gut versus the upper leg and the lower leg, and what we find is that two major changes occur. You see that in control, when a control subject is tilted, there's about a 10% decrease in the blood volume in the thorax, and there is about a 20% increase in the gut. And that makes sense that when somebody is tilted up, gravity pulls the fluid out of the chest and it starts moving downward. Take note, however, of the fact that, as shown in the cross-hatched lines, subjects with POTS show significantly greater emptying of their thorax and significantly increased pooling of fluids in the gut. Some of those changes, many of those changes rather, are controlled or regulated by blood vessels. So as I indicated earlier, one of the objectives of our studies is to understand how it is that the blood vessels control blood flow. And one of the methods that we employ, as I said earlier, is the use of skin as a surrogate tissue in which to measure nitric oxide. Nitric oxide is a regulator of many things in the body, and it's a very, very small molecule which is produced in many locations in the body and actually can cause a relaxation of blood vessels. This is a depiction of the laser Doppler flow that I mentioned earlier. We put it on the skin. It shines a light down into the skin, and I lost my pointer. I apologize. Okay, do you want to keep them? I'm so, oops. Sorry about that. View slides, oops. Trying to do too many things at once.
Marvin, can I put up another poll while you
Go right ahead,
set that?
thanks.
Okay. Just checking with our participants, over 300 at this point, on whether the pace of the program is too fast, too slow, or just right. A little kind of Goldilocks question. Well, Marvin, your New York background belies the answer, because with 85...
I'm going too quickly.
No, with 85% having voted, only 4% said you were too fast. 77% say just right, and 19% say too slow. So, so keep on.
Okay, so what I'm going to do, what I'm going to do is
I'm going to do one more while we're stopped. The level of information, in other words, whether it's too technical, too simple, or just right. I'll get a feel for that one also. Okay, and we have 83% voted, 84% say it's just right, 11% feel it's too technical, and 5% too simplistic. So I think the just
okay.
right
I think I think I'm just right. And this also justifies my earlier statement about the sophisticated and certainly well-educated nature of the participants today. I'll go a little more slowly.
Although it was fewer who wanted slow.
Fewer who wanted that. Okay, that's fine. Then I'll continue just the way I am. I must say that this is the strangest talk I've ever given, because despite the fact that my wife always complains that I talk to myself, doing so for this length of time is a bit bizarre. Anyway, getting back to what I was talking about, this may be a little clearer with the arrow rather than that little red dot. We put this laser flow probe on the surface of the skin. It shines a light into the across the skin, reflects off of these blood vessels, and gives us an indication of how much blood flow is occurring underneath the laser. In addition, we use a technique called microdialysis, cutaneous microdialysis, where we actually insert a tiny little tube under the skin. I'm sorry, I referred to this as the blood vessel before. These are the blood vessels that we're measuring. Rather, we insert this microdialysis catheter under the skin, and the microdialysis catheter has very tiny pores, and it allows us to inject drugs under the skin, with which we can artificially control the blood flow, as well as being able to infuse drug. These tiny little holes allow us to collect fluid, which we then use, we call it the recovered dialysate, for subsequent chemical analyses, some of which I'll show you later on. This is a little depict how we do it. We employ sterile techniques. Once again, this is all approved by the Medical College IRB, and although it looked uncomfortable, in fact it's not. Having had it done many times myself, I can attest to that. What we do is we numb the area of the skin with ice. We take a very, very fine 25 gauge needle, and we insert the needle under the skin, and then we insert this tiny little thread, the catheter, through the opening of that very, very small needle. So that'll give you some idea as to how fine this catheter or tube is. In fact, it's just slightly larger than the thickness of a human hair. We then pull it back so that the permeable, semi-permeable microdialysis portion is sitting under the skin. This is what the laser looks like, and then when we assemble the whole thing, This is actually the laser. This larger collar is the heating element, and as I mentioned earlier, we can heat the area under the skin. And this is actually one of my favorite slides. It really is quite relaxing because once you get over the minor discomfort of having those microdialysis tubes inserted under the skin, you can spend the afternoon reading, sleeping, watching television, or as many of our younger subjects do, texting. This is a skin response to heat. This is how much blood is flowing through the skin at rest, and as many of you know, when you get hot, your skin sweats, your body cools itself by diverting blood to the surface of the skin so that it can be exposed to the cooling air, and this is a demonstration of how that works in part. We impose heat. Over here it says heat start, and you can see that there's a characteristic increase of the skin blood flow from these about 20 arbitrary units to about 150, 160. The exact measurement is relatively unimportant. Suffice it to say that there is this characteristic first peak and then the plateau, and we compare the response from controls to those subjects with chronic fatigue and those with POTS, and we're actually doing some very interesting studies now where we use different drugs, which I'll talk about in a second. This is a little slide that shows that the skin is in fact responsive to those chemicals and drugs that we can insert or introduce under the skin. This is acetylcholine and increasing concentrations, and you see a dose-dependent increase in the skin blood flow. It shows, therefore, that this technique allows us to use pharmaceutical agents. This is a very interesting slide, at least from my perspective, that is showing the skin response to heat for control shown in the white, and notice that the response to heat in subjects with POTS is reduced. Now remember, before I talked about nitric oxide, which helps to dilate blood vessels. We and others have shown convincing evidence that in fact nitric oxide is responsible for this increased blood flow because if we introduce a substance here shown by the letters NLA, which is an inhibitor of the enzyme or chemical that makes nitric oxide, all of a sudden you can take a control subject and revert their response to heat to be similar to subjects with POTS, suggesting that in some POTS patients there is an alteration in the production or presence of nitric oxide, which is one of the factors that controls skin blood flow. In this depiction, we show two things. One is a recording of the heat response by measuring laser blood flow, and we actually, if you remember the slide I showed previously, we actually can collect the effluent or that which comes out of that microdialysis tube, and when we measure it for directly using a microelectrode, a measuring device that's sensitive to nitric oxide, you can see that in concert with the increased blood flow, we show an increase in the presence of nitric oxide that increases along with the introduction of heat, whose production also decreases once the heat is turned off. So these are among the studies that we do in the skin. And I spoke earlier about the fact that we're interested in what may be at hand in terms of some of the neurocognitive defects experienced by subjects who are, as indicated earlier, either orthostatically challenged or who have chronic fatigue syndrome. And we measure the transcranial Doppler ultrasound. This is a depiction of what's known as the circle of Willis, which is basically a traffic circle at the base of the brain through which blood flows, and then there are branches of arteries and blood vessels which thereafter supply the brain. We use an ultrasound probe which sits on the surface of the skull. This is non-invasive, and which allows us to measure the middle cerebral artery flow characteristics. This is a study subject just showing that this is the ultrasound probe. This is a little headgear that they wear to keep it in place, and we measure brain blood flow. Now, brain blood flow is very, very interesting because brain blood flow exhibits characteristics of autoregulation. And it's a good thing for all of us that our brain blood flow is autoregulated. By that I mean that the constancy of cerebral brain blood flow, that is the blood that supplies our brain, is well maintained over a large range of blood pressures. You can appreciate the fact that if your blood pressure drops, as it does transiently or temporarily when you go from lying down to standing up, if it wasn't regulated, your brain blood flow would drop, and you wouldn't have enough blood to maintain the necessary functions of the brain, in particular consciousness and cognition. The flip side of that is that if your blood pressure goes up, you do not want your brain blood flow to go up in concert with your blood pressure for various reasons, among them the fact that your brain is contained within a fixed volume, and if your brain blood flow goes up too high, it's not good for you. So that's the process of autoregulation, and this confounding slide just depicts, this is from a review by Dr. Ainsley, which was just published, which shows some of the factors which control brain blood flow. Let me point out that, as I mentioned earlier, carbon dioxide is very important, as are other factors. And I'm nearing the end of the talk. I know it's we only have 5 minutes until the hour is up, but if you'll bear with me, I just want to finish telling this story. These are the results of some studies that we recently published, which compares the arterial pressure and cerebral blood flow in POTS, shown by the gray line, and control subjects. The arrows here depict the beginning of and the end of a tilt. Now, use your imagination. This is very similar to what I showed you earlier for the blood pressure changes that are measured with the imposition of a tilt. In the control, there's actually a little rise, and then when the table goes down, their blood pressure comes back to normal. Notice, however, that in this particular individual, this is the recording from one individual. This is what we refer to as a representative graph, that their blood pressure tends to go down and it comes back up. Again, this individual did not faint. The more dramatic change can be appreciated while looking at the cerebral blood flow tracing. At the imposition of the tilt, there is in the control a gradual decrease and an increase with the return to supine of the cerebral blood flow velocity. However, look at the greater drop in the cerebral blood flow velocity shown here for the individual with POTS. Now, that was the overall change, and this slide shows some other rather interesting control aspects of the relationship between blood pressure, shown here as MAP, the mean arterial pressure, and cerebral blood flow. Notice here that this is a control subject who was lying down at the time and then tilted. And this is 1 minute after the imposition of the tilt. Here you can see that there's a rhythmic change in the blood pressure, which is what everybody experiences. And notice that the cerebral blood flow is relatively unchanged. Notice, too, that once the individual is tilted, there is a decrease in what's known as the pulse pressure. That is the difference between the systolic and the diastolic. But there are still these small oscillations and changes in blood pressure. But notice that the cerebral blood flow, by and large, remains steady. In contrast to the control, notice most dramatically that the cerebral blood flow goes from being relatively steady while supine to very, very wavy, and actually seems to be in concert with the changes in blood pressure, showing that there is a loss of control. There is a loss of control between, rather, there is a synchronization of changes in the cerebral blood flow with that of blood pressure. And earlier, what I showed you was that the controls with tilt, there's a change in blood pressure of about 10%, but in those individuals with POTS, that actually goes up to about 20%. Now, we just published a paper recently where we looked at individuals who faint, syncopal patients, to see if we can understand whether or not the changes that we see in POTS patients and controls regarding the regulation of their cerebral blood flow relative to their blood pressure, how that compares to people who faint. And this is a recording of pressure, arterial blood pressure, in an individual at baseline. Early on, after the tilt table goes up, and you can see that their blood pressure dribbles down, 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 and boom, this is the time of faint. In order for us to be able to compare controls to the fainting individuals, we artificially imposed the same timeline on our analysis of their blood pressure and their cerebral blood flow, so that we could say, for instance, at baseline, it looked like this in the syncopal, it looked like this in control. Obviously, since this control subject did not faint, we wanted to use the same time points following the tilt to make a valid comparison. And what we showed here is that in subjects who faint, look at how dramatically increased the change in their cerebral blood flow velocity is, and this is their diastolic. As all of you know, blood pressure is the high number, the low number, the systolic and the diastolic. We can also measure brain blood flow velocity in terms of how much blood is flowing at the peak, systole and diastole, and it just gives us an additional look. But the overall response to tilt is a dramatically increased drop in the brain blood flow in these syncopal subjects. I spoke earlier about alterations in blood volume, and this was a very interesting paper that was recently published, which shows that there is a dramatic difference in the blood volume of subjects with chronic fatigue. What made this study very, very interesting was that the authors compared chronic fatigue subjects to sedentary controls who exhibited similar activity patterns to fatigued individuals, and showed that while there was somewhat of a reduction of blood volume in sedentary controls, subjects with chronic fatigue syndrome had a significantly increased decrease, or had a significant decrease in blood volume levels. This is a comparison of our subjects which show that in chronic fatigue subjects, 3 of the 19 subjects that we studied with chronic fatigue had what's known as hypovolemia, or decreased blood volume, that had the characteristics of low blood cell volume and low plasma volume as well. That's the end of the information that I want to show you. I can summarize by saying that our perspective on the study of chronic fatigue is an integrative approach which seeks to look at those factors which can control local and systemic blood flow. Once we have a better understanding of that, we can look to make predictions about why some of the symptoms occur in chronic fatigue. Some of the work that we're currently doing, as I said, involves the studying the synchronization between brain blood flow and the control of blood pressure. We are endeavoring now to look at the local oxygenation levels in an attempt to see whether or not we can understand why individuals with chronic fatigue have this brain fog, certain neurocognitive deficits. We're also studying some aspects of neurocognition in our laboratory, in addition to the host of cardiovascular measurements that we make. I know I've flooded all of you with a tremendous amount of information. As I said, we employ an integrative approach. We generate lots of information. A large part of the challenge that faces us is knowing what to look at, how to look at it, but we're fairly satisfied that we're looking at the right cohort of subjects, that the information that we're gleaning will hopefully in the future be useful, and we're chipping away. I want to end by saying that I, as a researcher, and in particular one who is funded by the Chronic Fatigue Association, very much appreciate everybody's input, their participation, their contributions, both intellectual and financial, to figure out what's going on with many of these individuals. I've pretty much exhausted what I want to say, at least for this afternoon's presentation, and I'd be happy to answer any questions and turn the controls back to Kim to solicit some questions. Please appreciate that, as I understand it, Kim will be sending questions to me that reflect the general nature of the audience's interest, and I'll be happy to answer anything that I can.
Okay.
Thank you for your time, and look forward to hearing from the group.
Okay, we'll stay on a bit past our 1 o'clock planned ending time because there are quite a number of questions, and one of the ones that came across most frequently is recognizing the fact that you're not a medical doctor and you don't see patients in a clinical setting. Based on your observations and your experience with patients who have both primary orthostatic intolerance and also CFS, what management strategies have you found that can help people minimize and cope with these disabling symptoms?
Well, as you point out, you know, and as I've alluded to, we have a vast clinical experience, and I'm not giving out medical advice by suggesting the strategies that we have found useful and that many people have reported to us as being useful. One is maintaining your blood volume as best you can. by drinking lots of fluids, and I know many individuals derive benefit from drinking water, eating salty foods, and maintaining their blood pressure. We generally suggest the use of compression garments if and when appropriate. Jobst makes compression garments and surgical stockings and such. Many sports clothing manufacturers make spandex lycra tights and leggings, and if you one of the things, as I mentioned, that happens is you get a vertical displacement of fluid from the chest downward, and certainly if you wear compression garments, it mitigates that. It helps to alleviate some of that, and many subjects have found symptomatic relief in doing something like that. There's been a lot of interest lately in the benefit of exercise, and some of our colleagues have reported benefits from mild or moderate regular exercise, and I know it's a double-edged sword, because most subjects with chronic fatigue syndrome simply can't do any exercise, and the secondary effect, as many of you know, of doing exercise is you get that rebound excess fatigue following exercise. So what we recommend is that people start out slowly, perhaps doing a little bit of walking, doing something like a bicycle or a recumbent bicycle, so as to minimize the effect of standing up and doing things, and to start slowly and try and incorporate exercise in a slow, graded fashion. Beyond that, your physician might want to consider using some agents that act at the level of local blood vessel control, but as stated previously, I'm not licensed to make those sorts of recommendations.
I'm going to put out a poll here while we move on to another question, but there were several questions about conditions that might coexist with CFS and also with different forms of orthostatic intolerance, like migraine, let's see, Raynaud's.
Yeah. Well, I'm not sure what the relationship is with Raynaud's. Certainly we've seen a number of subjects who come in symptoms of orthostatic intolerance and or chronic fatigue in whom we've seen Raynaud's. What we typically see, what we see more often and quite regularly, is when we tilt people, their lower limbs become purple, suggesting the pooling of blood locally. So we see that. We certainly see our share of subjects with gastrointestinal complaints, very, very common, and perhaps the most common comorbidity that we see is the reporting of headaches and or migraines. These are commonly seen together, and if somebody comes into our practice and mentions any or all of these symptoms, we're seldom surprised, because we see it in a large subset of our CFS patients. It's the rare CFS patient that doesn't have a lot of these associated symptoms. What they're caused by, unfortunately, we don't yet know. I guess that's all I can say to that.
Okay. How about cardiac insufficiency, heart failure as a major complication? Do you see have any evidence for the existence of those things concomitantly with CFS or orthostatic intolerance?
I don't know what the demographic of the audience is today. My guess is that they are somewhat older than our subjects. We, Dr. Stewart and I, are part of the Department of Pediatrics, and most of the subjects that get referred as primary patients to us for the evaluation of chronic fatigue or of orthostatic intolerance tend to be somewhat younger than the general public, and usually are in their late teens or early 20s. As a result of that, the incidence of cardiac insufficiency and heart problems is virtually non-existent, which is not to say that there aren't teenagers and adolescents with primary cardiac problems, but the study subjects that we're allowed to investigate cannot have any underlying cardiovascular problems. That makes them ineligible for our studies, so the subjects that we see do not have any coexisting cardiovascular abnormalities. In fact, one of the inclusionary criteria are that they have to have normal cardiovascular function. As to the incidence of cardiovascular problems in subjects with chronic fatigue, I can't speak to that.
Okay. There are a few questions from people who wanted to know if you're still recruiting patients for this study or other studies. And
yes, we are. Our study is still open to recruitment. If you are interested, I believe there's a link to our study recruitment on the CFIDS site. I believe that's the best way to gain some information.
Yes.
If you would like to contact Kim, I can actually give you my email address. It's Marvin. I'm sorry.
Go ahead.
Go ahead, Kim.
I was just going to say we'll include the link in the follow-up message that
that's fine.
goes out after this. After this program, so people
that's
can see
fine.
your study and the other ones, because Dr. Shungu is still enrolling for his study as well.
Yeah, howling's a good word. You know, just as an aside for the people who are still signed on, one of the really terrific, from a personal and professional point of view, I'll editorialize now that the slides are no longer being flashed in front of you. One of the great things that the CFIDS Association has done is they've organized several really high-powered, intensive, scientifically rigorous meetings where people from many disciplines, different disciplines, get to share their perspective on this and other related issues. And they've done a tremendous job in fostering collaboration and integration of many different fields, all designed towards coming up with answers about chronic fatigue. So that's my way of saying thank you to the association, and I just wanted to make sure that the participants today can appreciate that as well. Yeah, Kim will provide you with my email address. What I will do following receipt of any of your questions is I may or may not get back to you very quickly because I'm actually going out of town for about a week and a half and will be unavailable via email. But when I come back, what I will do is I will review them with my colleague, Dr. Stewart, and if appropriate, I will forward them to our research nurse coordinator, Courtney Turilli, who may then get in touch with you for consideration of participation in either my study or some of Dr. Stewart's studies.
Marvin, could you pass the controls back to me, and we'll put some URLs up from our website that we'll give folks.
Sure, let me click on this. All right, so that's the end of my presentation. I just want to thank everybody for their attention and their time, and I'm sure over the next several months to years I'll have the opportunity to meet many of you. Thanks again.
Thank you. And I've got just some closing remarks before everybody heads off. I know we've gone over our time, and we appreciate your hanging in there. This is hopefully a little less tiring than having to get out and go somewhere, but it is, I know, takes a lot of energy just to follow a presentation with as many details as Dr. Meadows did. So thank you to all of you. And there are still many remaining questions. We both will have a copy of all the questions that were asked during the program, and may follow up with an article in our CFIDS link, our monthly e-newsletter that's listed here on the screen. I think that's what you guys are seeing. Yeah. So watch for that, because there were quite a number of questions about clinical aspects, about different different approaches that other groups use in conducting the tilt table test that do tend to differ by center. And we also plan to do another webinar on the clinical aspects of orthostatic intolerance with a clinician who can perhaps speak to more the medication side of things and what agents might be helpful depending on which type of orthostatic intolerance you have, because sometimes beta blockers are used, and other times other medications are like Florinef or fluorocortisone are more appropriate. So I am really now outside of my area of specialty. I don't even have a PhD after my name, so I won't go into too much detail on that, except to say that we know this is a topic, and certainly judging by participation today, for which there is a lot more interest, and we will keep that in mind. I also wanted to give you some information about our webinar series. As I mentioned at the beginning, this is the third program that we have had this year, and we will beginning in April, hope to have 2 programs per month that will vary between research topics like this one and clinical topics like just overall approach to treating CFS and orthostatic intolerance in particular, as well as some other topics like how to obtain disability if you're going through that process. So hopefully we'll have a variety of speakers, and some may appeal to you more than others, but that's one of the beauties of not having to make much of an investment in terms of travel or expense to take part in these. I also again, this is just a little bit more information on some of the topics to come, and we're lining up those speakers and scheduling those dates now. So watch our publications in the website and Facebook for more news about those. I also just wanted to put a plug in during the webinar last month that Suzanne gave. She mentioned at the very end of the program that we would soon be completing all the necessary steps to launch the first patient advocacy-owned biobank, and we are going to be making that announcement very soon. So this is a little sort of preview. It will be the first biobank of its kind, and we've done this in partnership with Genetic Alliance, using their infrastructure to create a biobank that exceeds standards for patient privacy and security. And we have already begun a collaboration for the first study using the biobank, and to meet the requirements of that study, we'll be recruiting patients through selected physicians to ensure that the diagnosis is made and all the appropriate medical evaluations are taken care of, and that the patients are well characterized when their samples come in. But we see this biobank as just a hugely important tool to advance research in CFS, and something that has not been available to be either patients who want to contribute blood and tissue samples in a way that will help a number of different studies, and also to researchers who bench researchers who are looking at markers and different things that don't have access to a big clinical population. So as Dr. Medow indicated, one of the activities we've done over the last couple of years is these very intense, rigorous scientific meetings, and we see this as a nice adjunct to the studies that we're directly funding and the network of investigators that we've built. So look for news about that in the next few days. But again, thank you very much, Dr. Medow, for sharing this amazing information with us today and for your time and preparation of very detailed slides. And I hope people have a better idea now of what some of these tests look like if they had never seen a tilt test. Some people think you hang upside down like a bat and get tested that way. So maybe we've helped some folks understand in a different way. And again, we'll be following up with more information in our publications as well as future webinar programs. And with that, we'll just close it out and look for a recording of this session on our website sometime in the next day or two, as soon as we get it converted over to the right format. So good day all, and thanks again for your participation. Thanks, Dr. Medow.
Thank you.